Question for Pamela. Pamela, just following on your talk right now with the Tamoxifen and AIs, one of the questions was that if you, with the extended time up to 10 years, if you're off Tamoxifen after your 5 years, what's the time lapse before you can start going back onto it? So if you've been off, you've taken your 5 years and you are now 5 years down the line post that, can you go back on it?
So we know that going back after 2.5 years actually still provides benefits. So 5 years later we don't have data we can extrapolate. It's likely. Like I said, I think it's better to be on hormonal therapy than not on hormonal therapy. And I think if you have recurred, that's exactly what we would do. If your tumor comes back at 8 years, we would start tamoxifen back up. So basically what we're doing is we're treating early metastatic disease.
And the second question for Krishna is, what's the risks with reconstruction for prophylactic mastectomies?
What's the risk for reconstruction? You mean what's the complication? Oh, yeah. I didn't assess that. Complication rate, you can divide it into two situations. The early complications, let's say 2 months after surgery, or the late complications. Complication rate 2 months after surgery, if you use an implant, you've got a 5 to 10% complication, meaning 5 to 10% of the patients will have to go back to surgery to revise the implant or change the implant, or in 3 or 4% of the cases, take the implant out. So inserting the implant at the same time than the mastectomy is a more complicated situation than doing it on a later stage. Once again, it should not prevent patients from getting immediate reconstruction. You should just seek the proper surgeons to do that. So all over, it's a 5% reoperation rate in the next 2 months. And then if you look at the long term, 20% of patients who do have implants complain about the implants. The implants get stiff, they get round, they get contracted. So you got to go for a reoperation in order to make them smoother. So 5% of patients get reoperated in the first 2 months. Probably 20% of patients will get reoperated in the first 5 years.
So we take a couple of questions.
Yes, we'll take some questions from the floor. So if you pop your hand up, I'll do the little walkabout. I could do with the exercise. So head down here.
I get my expanders out on Tuesday and silicone in. I'm beginning to regret it already that I should have a flap. But if in 10 years, when it is time to redo the silicone, can I get a flap at that stage?
Number one, you do not have to go back 10 years later. The lifespan of implants is anywhere between 5 years to 35 years. So I've exchanged implants that I placed 27 years ago, 3 weeks away. So you don't have to go back every 10 years. There is no data demonstrating that you should remove implants after a certain amount of time. You just follow them up with ultrasound, some cases MRI, but ultrasound does a great job. And as long as your implants are okay, you don't change them. This is number one. Number two, any implant for which you're not satisfied with the result long term can be made better. It can be made better by lipofilling, which is one of the great tools we have now, we didn't have 10 years ago, or you can exchange it and convert it to a flap.
Hi, this is for the tamoxifen. What are the risks in taking tamoxifen? And I've heard that there's a risk of ovarian cancer taking tamoxifen.
So the significant risks that are really worrisome are strokes, blood clots, and endometrial cancers. All of these risks are more prominent in someone who is over 65. Younger women don't tend to have this. The risk for endometrial cancer is about 1 in 800. The risk for strokes is a little bit commensurate with your underlying lifestyle. And sitting on the couch and eating little canapes is not a good lifestyle. So the risk of blood clots are significantly more in those who sit around than those who are a little bit heavier. So, and as we know now, it's like, exercise is key to breast cancer survival. I mean, even if you like to sit on the couch and eat your canapé, that's fine, but you need to get out on that hour and walk or do something.
Okay, I'm just going to pass the microphone into the lady with the lovely
I had a
red
call
scarf
from
here.
the director of the hotel. They're taking the canapes out of the brunch. I love canapes.
I hope they're not taking the wine away as well.
That's the second call. Wine is okay.
Wine's totally okay. It's like one glass, a small one.
Another question about tamoxifen. The side effects are pretty horrific. And even if they cut it down to half a dose, with all this technology and everything and drug trials and all the rest of it, why haven't they thought of something different? Why is there not more alternatives to tamoxifen?
You know, the problem is estrogen is the essence of being female. So, like, if you take that away, that makes it more challenging. It is, we don't know. And the problem is we're dealing with exactly the reason that causes breast cancer. That is estrogen. So we need to remove this. There are women who have no side effects on tamoxifen, and other people's life is just completely wrecked. And I see this. And I think there is where I said, like, you know, we all make choices. Work with you. So what doesn't work well is like just, not taking your drug and telling your doctor, yeah, fine, taking it every day. That doesn't work so well. It's like trying to find something else. There are Tamoxifen, there's Fastodex, there's aromatase inhibitors. We can work a little bit. We can take it every other day. We can ease you into it. It's like, but in the end, I think the important part is, in the end, in your mind, you have to have made a bona fide effort that you tried everything, because if things turn bad, you have to be able to sit there and say, like, well, you know, I tried my best and it didn't work out. That is a lot better way to live it than just, like, you know, cheating yourself. Never works that well.
This is another question on this is the long-term hormone treatment. Do you know if there's any difference in terms of HER2 status with regards to those results?
Yeah, we do know that in HER2-positive diseases, like, it doesn't matter which drug you take. I mean, it seems like the aromatase inhibitors are significantly better in those with lobular carcinoma. In a HER2-positive, either drug is fine. And like I said, like, for me, as long as you can stick with one drug, I'm fine with either. You know, the thing is, like, HER2 targeting is important part in HER2 positive disease. You need to stick with the year of Herceptin. That's probably a better bet. But hormonotherapy still works. I mean, so don't underestimate the benefits of hormonotherapy.
Okay, I'm just going to head over here to the lady in the grey jacket, if we can pass the microphone across.
Thank you. You talk with the tamoxifen about being 10 years on the tamoxifen. When you transfer from tamoxifen to letrozole or the sorts, do you need to stay on one of those for 10 years or?
Yeah, so I think we can transfer from tamoxifen. Tamoxifen is a premenopausal drug. For all of those patients who've been diagnosed when they were premenopausal, we transition at some point. As I said, it's like we don't know what's better, whether 10 years of tamoxifen, 5 and 5, 10 years of an aromatase inhibitor, we don't have that data. And given the significant impact on quality of life of either drug, take the one that you tolerate.
Just to follow on from there, there's a question here to say, what after 10 years?
Oh, well, that's an excellent question. Taking a break? We don't know. It's like, and as I said, many of our patients have no side effects to stay on. We don't have that data yet.
In trying to get through the side effects, I've done both things, and my question's to you about, do you know of ways to manage them? For example, if you've tried all the things like citalopram, etc., to deal with your hot flushes with tamoxifen, do you know of any studies where a small amount of estrogen replacement has been used? Or the other side of my question is, if you're trying to persevere with something like letrozole and you've got the arthralgias, what are potential things can you use there? Can you use things like glucosamine and chondroitin? So for those of us who are trying to make it through the 10 years, what adjuvants can we put in there to help us deal with the treatment? Are there studies around that?
So in terms of what data we have in dealing with the arthralgias, is like, I mean, actually exercise, regular exercise has helped the most. Of all the remedies we tried, exercise helps the most. Walking may not be the best for arthralgias, maybe an elliptical trainer, which sounds pretty horrendous, or like a bike. I mean, you live in a beautiful country, take the bike out and go for a bike ride and go in the forest, go in the sun. I mean, obviously with sun protection, but I think this exercise has to be part of your life.
Okay, question over here.
And in terms of taking estrogens, I'm a medical oncologist in the US. I mean, this would be complete heresy for me to say that you could take estrogen, just to be clear here.
I just had a question about reconstruction. What are the options in terms of nipple reconstruction? Are there many?
No, you don't have many options. Not talking about the areola, I'm just talking about the nipple. You have two options. The first option is to take half of the other nipple and graft it, which is a painless operation that does not reduce the sensitivity of the part of the other breast. That gives great results. The other solution, if the patient doesn't want her other nipple to be shed, or if the nipple has no projection, is to create a little, what we call a flap, meaning that we work with the skin over the implant or the flap and make that skin projected. So you have really two options, a graft or local skin, which is shaped to make a nipple. As for the areola, you can tattoo the areola, you can skin graft another part of the body, usually the inner thigh, and this gives great results. But no sensitivity.
Just time for a couple more questions here. We have one, this lady in the orange round here. I'm just going to head it over.
Is weight gain a recognised side effect of aromatase inhibitor, or should I be blaming Cadbury's?
When it comes to weight, it's always easy to blame something else, right? Yes, absolutely. It's well recognized in the placebo-controlled studies that there's a significantly higher increase with the hormonal therapy than not. As you know, many patients gain weight as they go through menopause, so it's a double whammy going through menopause and then having hormonal therapy. There are things to do about weight gain. They are also not that easy. In the US, we estimate 65% of women are overweight, and that is probably not coming from the fact that it's easy to lose weight. It's just really, really hard to lose weight. But making an effort. And I think what we learn more is the weight gain is less of a problem than the lack of exercise. So if you can only do one, if you can't forego exercise. It doesn't matter what your BMI is. People who exercise do better than people who don't exercise, regardless of weight.
Okay, and just here.
Yes, just a couple of things. I had the immediate reconstruction bilateral mastectomy, but I noticed no one gives statistics on infections and things like that. I actually am now going through, after 6 months, I've got an expanders, and there doesn't seem to be, I don't think there's enough said about what can go wrong.
So the situation is you've had expanders placed, right?
No, I had an immediate reconstruction.
But with implants or expanders?
Yes, implants.
Implants. Mm. And now what is the exact question? I didn't get it, I'm sorry.
Well, I had an infection, had to have them taken out. Yeah.
Okay, so you're one of the 5% of patients who get their implants taken out after reconstruction because of necrosis or infection. If you didn't have radiotherapy, there's no radiotherapy.
No.
We would fat graft. We would discuss with you if you have a little fat somewhere that you don't like. I see patients coming to my clinic and they're with friends, and some of my patients in Paris are really skinny, and the friends always says, I can use mine.
Yeah. No, I didn't have it. I had the expansion, and I'm just waiting 3 months now.
So the idea is you can make your result with implants much better by using fat grafts. And this is a way of getting your implants softer with a better coverage. So if there is a problem after an implant, before we would say use a flap. Now we have an intermediate step at the ladder saying try to fat graft in order to make this suppler and keep the flap if the fat graft does not work.
Yeah, my surgeon said I couldn't have fat graft.
He what?
He didn't recommend a fat graft, yeah.
It's difficult to discuss individual cases, but really one of the options between implant and flap, if it's feasible, it's not always feasible, is fat grafting, really.
Okay, one final question, because a lady didn't feel that it was fully answered before. She asked about any possible link between increased ovarian cancer risk and tamoxifen. Pamela?
There's no link clearly with tamoxifen and ovarian cancer. There's a link with endometrial cancer and tamoxifen. Now the challenge is, as you know, is like, remember my talk about the BRCA mutation? There's a significant increased risk for ovarian cancer in those who have BRCA mutations. BRCA mutations are common in women with breast cancer, and there's a high risk of ovarian cancer. So we have had a little bit of a hard time sorting out whether the ovarian cancer risk is associated with tamoxifen or not. But I think all the randomized data now point to the fact that it's probably not the tamoxifen. It's really the increased risk of having ovarian cancer in those who carry a mutation. And that's not just BRCA1, this is ATM as well, and RAD51.